Now, in terms of how we'll do tonight, obviously I'll have a lot of slides, I'll do a lot of talking, but if people have questions along the way, I don't mind if you put up your hand and ask a question. So to try and make it a bit interactive, I will leave time for questions at the end. So but if you've got a burning question that relates specifically to what I'm talking about at the time, and you feel like you really want to ask it at the time, that's fine. Just put your hand up and we'll try and answer it as we go. If there are things that you feel that you can wait till the end, then please do that as well, and we'll have some question time at the end. So we'll just see how we go. All right, so anxiety disorders and PTSD. I've put PTSD separate to that because if we look at the current classification, looking at the DSM-5 system, PTSD is classified differently. It's no longer considered an anxiety disorder, it's one of the stress disorders. So I've put that separately and we'll look at it as a slightly distinct issue. Anxiety disorder is a huge topic. We're not going to be able to cover it in as much depth as I would do when I was studying psychiatry, where it would have been done over 10 weeks in 10 lectures or something like that. So it's going to be a bit of a quick cook's tour, but hopefully by the end of tonight you'll know a lot more about anxiety disorders, know what different types of anxiety disorders there are, how to distinguish them, and how to treat them in broad terms, what you can do in primary care, what are the things you can do to kick off treatment, and when to refer on to psychologists and psychiatrists, because of course that's a really important component as well. So what are the common anxiety disorders in primary care? And so that's what we'll be talking about tonight. Pharmacological management, obviously that's really important. That's a really important role for GPs. How do you medicate somebody with anxiety? Benzodiazepines. We'll be talking about the use and misuse. There's lots of mythologies about benzos. I believe there's mythology about how bad they are and how good they are. I think they're neither as bad or as good as they're made out to be, but I think it's really important to understand how they should be utilised and to use them sensibly. Obviously the principles of psychological management are really important. Whilst I wouldn't expect any of you to be able to deliver all aspects of psychological therapy, I think having a good basic understanding of psychological therapy will help you to direct your patient into such therapy, and also know when your patient is getting correct therapy or not, and when to perhaps find alternative treatment for your patient. And then we'll talk about PTSD and the changing face of PTSD and how it's evolving and how that might be reflected in the patients that you see. All right, so here's kind of a list of anxiety disorders as they currently are depicted within the classification system. Now, as we go down that list, are all of those, and I've put PTSD at the bottom there, but are all of those disorders familiar to you? Are there any there that you look at and go, gee, I've never heard of that one? Any there that strike you as being unusual? Or?
Illness anxiety disorder, I haven't heard of.
Illness anxiety disorder, okay. That's kind of a new term or a new name. Has everybody heard of hypochondriasis? Yeah. Not a great term, is it? It's quite a descriptive term. I don't mind it actually from a purely descriptive term. I like descriptive terms in psychiatry. I like manic depression. I don't like bipolar. But we don't call it manic depression anymore. We call it bipolar. I like schizophrenia. It's still called schizophrenia, but I suspect at some point in the future it won't be because it's kind of got a pejorative, ring to it. So hypochondriasis, it's got a historical, ancient kind of background to the term. We all know where it sort of comes from. The Greek term, the hypochondrium, which is the abdomen, which is where a lot of hypochondriacal symptoms have arisen. It was first described, I think, probably by the ancient Greeks. And that's sort of how the idea arose. Somebody who develops somatic symptoms of unknown origin in the abdomen is a hypochondriac. We don't like to call people hypochondriacs, and we shouldn't. So the name has been changed. But illness anxiety disorder, it's a bit of a sterile term, but it in a sense, and I'll talk about what it actually is, but it's the same sort of thing. Now, separation anxiety disorder is on that list. We often think about that as being a disorder only of children, but in fact it can occur at any age, and I'll come to that in a moment. So these are the common disorders, and I'm going to go through each of them in turn so that you get a better understanding of what they are. Okay, GAD, generalised anxiety. Essentially, the core feature of this condition is excessive worry, or what we might consider apprehensive expectation. All right, so, and it can relate to multiple areas in a person's life. Again, it's often relevant to the developmental age of the person. So a younger person, a child or an adolescent, you're going to be worried about school, particularly. An older person, worry about the workplace. Relationships are often a very key area of worry. Finances, particularly for adults, less so for children. And health, again. And the worry is difficult to control. I mean, we all worry at various points in our lives, but hopefully the worries come and go, and they can be controlled. But for somebody with GAD, they just can't control their worries. The worries overtake them and they ruminate excessively. And then they get a whole lot of physical problems. So they get fatigue, they get muscle tension, they become irritable, they can't concentrate, they're restless. And particularly they have sleep problems. So if you ever have a patient who comes in, they can't sleep, think about GAD. It's a very common source of sleep disturbance. All right, so that's GAD. And we'll come back to the treatment issues, but that's kind of your core features for diagnosis. And it tends to be a persistent chronic disorder, as many anxiety disorders. So once somebody's got this, unless it's well managed, it's chronic. It can be lifelong. And it often slips under the radar as well. I mean, you don't get hospitalised for GAD. You just live with it, yeah? And often becomes almost a feature of that person. They're a worrier. That's the personality type, right? That's what we think about. But in fact, it's an anxiety disorder. Separation anxiety. Okay, so this is where somebody has quite marked distress when anticipating or experiencing separation from home, the base, you know, where we feel secure and safe, or major attachment figures. Okay, you know what I mean by an attachment figure? So it's the person in their life, so a parent if you're a child, or even an adult perhaps, or a partner. Okay, so major attachment figures. Or a carer. I mean, I work in disability, so if you're somebody with a disability and you're living in a group home, it could be your carer. So who's the major attachment figure that you depend upon for your nurturance, emotional nurturance? Now, you can already see here that there are certain people who are going to be more vulnerable to this. So people who are more dependent, people who are less capable of being on their own. Okay? Worry about losing the attachment figure or harm befalling them. So when they're away from their attachment figure's off doing something, they worry something bad will happen. And if something bad happens to them, how will I be able to cope? The fear of being alone, going to sleep without that major attachment figure being present. Then you have substitute attachment figures, you know, like safety blankets or cuddly toys, you know, all these sorts of things. And then they get nightmares and other physical symptoms related to it. So you can see why in children it's very common. You might even argue that it's developmentally appropriate for a small child to have separation anxiety. You wouldn't worry about a 3-year-old having it. You might worry about a 15-year-old. You'd certainly worry about a 35-year-old having it. So it's all about what's developmentally appropriate, okay? Social anxiety. Okay. Now, of course, some degree of social anxiety is present in all of us, depending on the circumstance, right? So, you know, I don't particularly get anxious getting up and giving talks, but a lot of people do. A lot of people find that prospect quite terrifying. There are other social situations that I probably find, you know, myself more uncomfortable in. But, you know, so again, these social anxiety is not feeling uncomfortable in any social situation. It really does depend on these key features, okay? So it's marked fear. It's quite prominent and significant fear. And what's the fear about? It's really about being exposed to scrutiny by others. So the person believes they're being scrutinised by other people in their social environment. So it could be social interaction, having conversations, meeting somebody unfamiliar at a party, for example. It can even be observed. So people just sitting in a restaurant eating, worrying that people are watching them eat, or maybe sitting on a train being watched. Or, of course, performing. A performance anxiety is a classic one. Giving a talk, you know, getting up on stage, you know, musicians get it all the time. And the fear is about negative evaluation from others, that they will do or say something that it will either result in rejection, people laughing at them, causing offence, they'll be embarrassed or humiliated. Yeah? Does that make sense? And we'll talk about the consequences of anxiety in a moment. I just want to go through what the types of anxiety, and then we'll talk about what does it actually do to people, what does it cause. Then we have panic disorder. Okay, so in panic disorder, people get this recurrent, unexpected panic attack. So what is a panic attack? It's a sudden surge of intense fear or discomfort that reaches a peak within minutes. Okay, so it comes on very, very quickly, and then it subsides, but it subsides a bit more slowly than it comes on. All right? And there'll be multiple symptoms all occurring at once. So they'll get palpitations or sweating, shaking, shortness of breath, dizziness, nausea, tingling, derealisation, which is feeling like everything around them is not real or that they're not real. And they might fear dying or losing control of themselves. Then they develop other things, so a worry about having panic attacks or anticipatory worry or anxiety. And then you get the agoraphobia that goes with it, which is the fear of being outside of the home, such as being on public transport, shops, crowded places, because if they're in that situation, they may not be able to escape in time. They may not be able to get away, and then they'll get a panic attack, and if they get a panic attack, they may not be able to get help. So this whole cascade happens. So that's essentially what panic disorder is. So you can see how this is quite different to, say, generalised anxiety disorder, where there's no intense physiological arousal, it's just a worry. You see what the difference? Okay. Now we've got illness anxiety disorder, which used to be called hypochondriasis. And it's really a preoccupation with having or acquiring a serious illness. Okay. Now it is different to people who complain constantly of having lots of symptoms. So although you can have symptoms in illness anxiety disorder, they tend to be relatively mild. It's more the belief or the worry that you will develop a disease or that you already have a disease. Does that make sense? So you can have symptoms, but often they're relatively mild, and just the hint of a symptom will be enough for the person to then launch into this idea that they could have something. So I had a patient the other day who said that she had some fatigue. Fatigue is a very common symptom. So she did the Dr. Google. Do we all have patients who do Dr. Google? We probably do it ourselves sometimes. I've been guilty of it. So she did Dr. Google, and before she knew it, she'd reached leukemia. And she honestly believed she had leukemia. She was off to the GP getting blood tests. Now, of course, this is where we'll talk about the role of the GP in all of this down the track. So the preoccupation is clearly excessive or disproportionate to the actual risk of developing that disease. Okay? And then the health-related behaviours that go along with it. So repeatedly checking the body, checking for lumps, checking for other signs that there might be something wrong, or searching repeatedly on Dr. Google. And there are kind of two types, either care-seeking or care-avoidant. Care-seeking is the patient who will go to the GP constantly, repeatedly, far more often than they need to, asking for more tests, more blood tests, more CAT scans, more ultrasounds, more whatever. Then you've got the care-avoidant because they're so fearful, they don't want to know. They just don't want to know because they're terrified of what they'll be told. I've got this disease, but if I've got a disease, I don't want to know about it, so they just won't go along. But then they'll keep ruminating and worrying about it, but they just don't want to find out. Yep, Phil.
Parents who worry about everything with their kids, is that a variation on this? Or they've
Yes.
got a lump doctor, they've got a rash.
Yes, that's kind of by proxy. You'd almost call that illness anxiety by proxy, and they can induce it in the child as well. Yeah, that's a really good point.
At some stage, can you mention when does a variant of normal become a disorder?
Did you have an example in mind, or?
People
Yeah.
have anxiety.
Yep.
People have an anxiety disorder.
Yes.
The person gets labelled, the other doesn't. Where does the disorder come in?
Okay. All right. Look, it's probably a good time to raise that issue. I mean, clearly, anxiety, and I probably should have. Maybe we should kind of deal with that issue right from the outset. I mean, anxiety as a mechanism, if you like, is evolutionary. We all have an inbuilt capacity and we need to have that inbuilt capacity to feel anxiety. If we didn't have the capacity to experience anxiety, we could not survive as an individual or as a species. We all accept that, right? I mean, if we're walking across the road and a car tears down in front of us and is going to hit us, if we didn't have that capacity to feel immediately anxious, jolt, and be able to run back and jump out of the way, and have our heart racing and immediately for a few seconds go, oh my God, I nearly died then that would be bad for us as an individual, and as a species, collectively, that wouldn't be great. Do we agree with that? And there are other situations, you know, caveman, if the caveman wasn't anxious about certain types of animal that was going to eat him versus other animals that were fairly harmless, you know, that's you're not going to survive. So it's an inbuilt evolutionary mechanism, fight or flight. Essentially that's, you know, some things you can stand there and go, I can beat you off. You know, you're not going to get me. Other things, no, I'm sorry, you're too big, you're too scary, I'll run the other way. So anxiety is an inbuilt evolutionary mechanism. The problem with anxiety disorders is that it's an inappropriate or excessive development of anxiety that gets through sensitization. Whoops, do I need to keep touching this? That gets, through sensitization, gets built greater and greater and greater to the point where the person develops a fear, an inappropriate or excessive fear that can't be extinguished or habituated. And we'll talk about that as we go. So that's really what an anxiety disorder is. So anxiety, normal, appropriate, healthy. Anxiety disorder is when that's become clinically significant. Now, drawing the line can sometimes be difficult. I accept that. And there are times when you'll have things like adjustment disorders, where for a period of time somebody might develop anxiety in relation to a stress. It's time limited, it's temporary, it settles down, you don't treat it. It's still abnormal, but it's not to the point where you would say it needs to be treated, it needs some intervention like a psychologist or medication. That's because it's time limited. But when it's persistent for a length of time and it's going on and it doesn't appear to be linked to a specific stressor that's now abated, then you need to treat it. Does that make sense?
Well, with adjustment disorder, I frequently don't use that word and say adjustment reaction.
Yep. Because
I don't want the person labelled as having a disorder.
That's fair enough. That's fair enough. I don't mind that really. So I might leave that broad issue for the moment. We might come back to it if we need to. Okay, OCD. So this is quite different from the other disorders. And the treatment is a bit different as well. But at the moment, I'm just going to describe what it is. You should all have a general idea what it is, but it is a bit unusual. I want to make the distinction between OCD as a disorder and people who are obsessional or perfectionistic. We often talk about people who have a perfectionistic personality style. Oh, that person's OCD. They're really OCD. In fact, they're not. They're just really rigid and obsessional in their personality style and in their thinking. Do you understand what I mean by that? That's a very common thing. In fact, a lot of doctors, a lot of us in the room, collectively, I'm not saying any of you individually or me or but collectively doctors tend to be, more so than the general community, obsessional. And that's not necessarily a bad thing to a point. It can be a bad thing up to beyond a point. And that's, you know, so it's about perfectionistic, being rigid, perhaps, you know, overly analytical, unable to move on beyond, you know, and getting bogged down in detail without seeing the big picture. That's an obsessional personality. Obsessive compulsive disorder is this, okay? So the obsession is the recurrent or persistent thought, images or urges which are experienced as unwanted and intrusive. Now I contrast this with GAD, where the worries are experienced as being what we call ego-syntonic. So they seem completely consistent with a worldview. So I'm worried about my finance, I'm worried about my relationship, I'm worried about work. That seems completely normal to me because, yeah, of course I'm worried. These are real things to me that I should be worried about. Everyone else might say, oh, I think you're a bit excessive there, but for the person with the GAD, they see that as being entirely plausible and consistent with their worldview. The person with OCD will say something quite different. They'll say, no, actually, these thoughts I'm getting, if they'll tell you at all, because often they'll be very embarrassed by it, they'll say, no, these thoughts I'm getting are really very distressing to me, because the thoughts are usually about things that they don't want to talk about. They're about violence, they're about sex, they're about religion. They're quite disturbing thoughts. So For example, a young mother will have thoughts about going to the kitchen, getting a knife out and stabbing her baby. That's a classic obsessional thought. A very religious, proper woman will have thoughts about having some wild sexual activity with whoever. Certainly not her beloved or anyone that she should be having sexual activity with. A nun, for example, a nun with OCD will have crazy sexual fantasies, not fantasies actually, but intrusive thoughts that are ego dystonic. So you can see where this is quite different to GAD. Do you understand where I'm coming from? So once these thoughts enter the person's mind, they just can't get rid of them. They'll, of course, rather than letting them come and saying, well, they're just thoughts, they'll try and suppress them, which is natural when you think about it. When you first get OCD, your immediate reaction is, I want to suppress it, I want to get rid of it. And so they'll try and suppress or neutralise with another thought or a compulsion. So the nun, for example, what compulsion do you think a nun's going to have if she's getting sexual thoughts? Praying, exactly. And the praying ritual then goes from being what might be a standard kind of prayer for a nun to becomes a compulsive ritual. And it's done in a ritualistic way. It might be, I've got to pray a certain number of times at a certain time of the day, and if I do that, my obsessional thought will go away. For somebody who has a terrible fear of being unclean, dirty, their ritual's going to be washing. You know, I've got to wash myself, got to wash my hands a certain number of times to the point where they've excoriated their skin. I mean, has anybody ever seen patients where their skin's... Yeah, I mean, so the compulsions are repetitive behaviours, washing, checking, ordering, praying, counting. They can be physical or mental rituals. And they're driven to perform in response to their obsession. They're not connected in any realistic way. These are completely unrealistic and what we call magical thinking. So the idea that doing these things will actually in any way negate the thought you're having is purely magical, but it does work temporarily. But the cost to that person is huge. It's an emotional cost and it's a time cost. Sometimes it takes hours every day. A person can't leave the house. They can't do their job. They can't fulfill any of their normal roles because they're completely bound by their rituals. And they can sometimes lose insight. So sometimes they'll retain insight and understand what they're doing is completely abnormal. Other times they'll lose insight, almost be quasi-delusional. They'll start to almost identify with the belief, and it almost becomes a delusional belief. Does that make sense? Okay, so that's OCD. So what are the features that could broadly be considered common to all of these anxiety disorders? Okay. So the first one is avoidance. So you can see there, we've already talked about some behaviours that are really about avoiding. So the person with anxiety is really trying to avoid a situation where they're going to feel anxious, which is understandable. Nobody who's had severe anxiety wants to feel that again. So it's natural for them to want to run away from that and avoid it. So they'll avoid the feared situation or a stimulus, and that becomes a learnt behaviour. So let's say, for example, you've got severe social anxiety, and that your social anxiety is triggered every time you go to a party or a social function where there are people around that you're unfamiliar with. And then you try and go a couple of times, and as soon as you walk in, you see a crowd of people and you go, oh my God. So the first thing you do is you run away and you leave. What do you think happens to your anxiety when you do that? It jumps down, it just plummets down. And then what do you think that does in terms of a learnt behaviour? It reinforces it. It says, okay, if I leave the situation, my anxiety goes down, it's great. That's my go-to mechanism. I'm just going to, every time I feel like I'm really anxious, I just leave. I escape. There's another way of dealing with it, which is number 2, okay? So the first one is avoid. Run away, leave it, stay at home, don't even go in the first place. That's the agoraphobia. So I've just learnt, if I don't go in the first place, I won't feel anxious, so I've learnt that behaviour. The second one is to only endure it through a range of safety behaviours, okay? So the first safety behaviour is cling on to someone, have somebody with me all the time. So I can't go out or I can't go there unless I've got person X with me. It could be their partner, it could be a best friend, it could be anybody, and so they've become totally reliant. And you've probably seen patients who maybe can't even come to you in your surgery without somebody being with them. Do any of you have patients like that? Yep. So they're totally dependent on that person, otherwise they're too anxious to go out on their own. But the other one, I think, is a very insidious safety behaviour, and that's the use of alcohol and drug and benzos in particular, in social situations, but also for people with panic attacks. So the use of alcohol, alcohol as a social lubricant for social anxiety. I've seen so many people with social anxiety who actually present with alcohol dependence. They come in for detox. And when you unpick it all, it's like, well, how did you start drinking? Oh, well, I used to get a bit anxious when I was going out. Started to drink, made me feel better. Drink a bit more. Couldn't stop drinking. So, really, you've got to look for these behaviours as a way of unpicking what's actually going on behind the behaviour. Then the sensitisation to the feared stimulus leads to increasing anxiety. So every time you do one of these behaviours and you learn that you can avoid anxiety or you can reduce anxiety, if you try to confront the anxiety, the next time you become more anxious. So it's like a cycle that goes up, because you basically become helpless. You've become unable to cope with the anxious or feared stimulus without the safety behaviour or without avoidance. So if you try and do it any other way, your anxiety's gone up. You've primed yourself. It's like a priming mechanism. And you've got this thing called anticipatory anxiety. Okay? So next time, you're not only anxious when you go, you're anxious before you go. You're anxious about the anxiety. You've developed this thing called anticipatory anxiety. So it's really very crippling. Okay, so now if we are looking at just the broad assessment issues, genetic factors are important. If we're looking at all mental disorders, genetic factors are important, but in anxiety disorders it's no different. People think, well, it must be something to do with their childhood, it must have been the way they were brought up. Look, those things are important, but genetic factors are actually probably the most important. So a family history is almost always positive for somebody, a parent, an uncle, a brother, a sister, having some anxiety. Comorbidity is also very common. So if you've got one anxiety disorder, you're often going to have another one. So if they've got GAD, maybe they've got social anxiety, maybe they've got panic, maybe they've got illness anxiety, and often they'll have depression as well, and of course substance abuse. So don't just think they've got one, look for others as well. There is a female preponderance in anxiety, possibly not with OCD and with PTSD, which we'll talk about. But the other anxiety disorders, definitely a 2-to-1 minimum female preponderance. They frequently present with physical symptoms, which you've already talked about. Okay, so look for the anxiety disorder that might be masked by the presentation with vague, poorly explained, multiple physical somatic symptoms. Okay, particularly the person who's consistently asking for investigations when you think they may not be warranted. And it can occur across all ages. So children, adolescents, young adults, older adults. So it crosses the lifespan. This is not a disorder that only emerges in a particular age group. It's right across the lifespan. More so than in other psychiatric disorders, which, after adolescence, they really jump. Anxiety disorders definitely occur in younger children. You treat them differently, and perhaps they've got a better prognosis. So like we said before, separation anxiety in a small child, you're not going to be that worried about it. You're more worried about it if it occurs in an older adolescent. Okay? But you still need to do something about it in a younger child, because in fact you may be needing to look at the parent, as you said, Phil. You may need to see whether the parent's got the anxiety disorder. They may need treatment because they may be inducing anxiety in a child who may later themselves develop anxiety. So you may do, the best treatment you might be able to do for that child is treat their parent. Okay, so let's look at, for the moment, some pharmacological options. Okay, so a good, simple thing to remember is SSRIs, first line for anxiety disorders, across the board. Are there ones that are better than others? Look, I think it really depends on issues around tolerability. I mean, my preference with SSRIs, generally in an adult population, so I'm going to leave aside my developmental disability stuff. If we're just talking about a general adult population who are otherwise healthy, I like escitalopram. That's a good first up choice for me because it's usually well tolerated, has very few drug interactions. But all of them are pretty good. I mean, I tend not to use much paroxetine these days. I don't know if anyone uses much paroxetine. That's kind of gone off my list. But I certainly use citalopram. I certainly use sertraline. And look, fluoxetine is good insofar it's longer acting and it doesn't have the problems with discontinuation. So there are some patients where I will use fluoxetine, but you do need to worry about, or you need to look out for drug interactions, and also with fluvoxamine as well. But you know, escitalopram I think is a good first line, and I'm tending to use that a lot, and with depression as well. Any questions about SSRIs using in anxiety? People pretty comfortable with that?
I've used the rimmers. Do they ever work?
Beg your pardon?
Rimmer?
A REMA?
Do they ever work for that?
Look, you know, meclobamide, that's the only one you're referring to, I guess, yeah. Look, I think they've really gone out of fashion. Certainly I've discussed this with some of my colleagues. I don't know that any of my psychiatry colleagues are using meclobamide much. I did use it for a little while with social anxiety. I mean, there was some linked or evidence for social anxiety. I found it a bit disappointing. I had to use quite high doses. I probably wouldn't completely exclude it, but I can't remember the last time I prescribed it, so that probably tells you I'm not that great a fan. It's very well tolerated, but like most drugs that have no side effects, they don't have much of a good effect either, you know. Yep, question?
You mentioned fluvoxamine, which is Luvox.
Yes.
I tend to use it a bit because it gives a bit of sedation.
Yes.
But you mentioned drug interactions.
Yes.
Could you mention that, please?
Yeah, look, I can't tell you, I can't remember all the drug interactions, but I know it definitely does interact with the cytochrome P450 system, so I can't remember if it's 2D6 or CY, which one of those, but you do need to look out for drug interactions. Definitely warfarin if they're on warfarin, but you know, that'll be an older patient. But I think there are some other medications and even some psychiatric medications, like some of the antipsychotics, and maybe some anticonvulsants. So there's quite a few with fluvoxamine and fluoxetine that you need to look out for, but you know, just check it out on, you know, when you do your drug interactions. But I do use fluvoxamine as well. In fact, I would mainly use fluvoxamine with OCD, and I'll talk about that separately because I want to talk about OCD a little bit separately for medication, because that's a bit more complicated. Not much, but a bit. So second line after SSRIs would be your SNRIs. I reserve them as second line because possibly they're not as well tolerated, although generally they're still pretty well tolerated. My preferred SNRI, I keep going back to venlafaxine because I just think it works better. You know, I do use a bit of desvenlafaxine. I just don't think it's as good. Duloxetine is probably okay, but again, I just prefer venlafaxine. I think it's the best of them. And I do use mirtazapine. I think it's a good drug. It's obviously got the benefit of having some sedation properties. You can use it at quite a low dose, 15, right through to 30, 45, even up to 60. So mirtazapine, I think, is a good medication. So I think all of the first and second line, you're in good territory. Once you get to third line, look, quetiapine is one of these drugs that's a bit of a catch-all these days. Certainly amongst psychiatrists, when I see somebody on quetiapine, it doesn't mean anything diagnostically. They could have anything from psychosis, bipolar, depression, borderline personality disorder, anxiety, eating disorders, almost anything, because it is used that widely. In anxiety, it's often used for insomnia. It is good for insomnia, but it has a lag effect the next day. It will make people sleepy the following day, and it can put on weight. So you've got to be a bit careful. Similarly, olanzapine has a similar kind of profile. So be a bit careful with that. And some people do describe this fogginess in the head. You know, they don't like it for that reason as well. Pregabalin, you know, we're now getting down to fourth line, and pregabalin is a medication that is, you know, purported to be useful for anxiety. I've used it a few times. I think it's been helpful, although often they're patients who are on other medications, so it's hard to know exactly what impact pregabalin's having. But I'm open to using it more. I'll probably get more experience, you know, with it over time. I certainly don't use it a lot, but it's generally well tolerated. I don't find people getting huge side effects with it. So it's kind of, I might have a better idea over time whether it's going to be really helpful. But in theory it should be. It works on the GABA receptors in the same way that benzodiazepines, but it doesn't have the issues with tolerance and dependence that you get with benzos. Yep.
What is about the side effect of selective serotonin reuptake inhibitor? For example, the withdrawal syndrome or something like
The which syndrome?
that. Withdrawal.
Oh, withdrawal, yeah. Well, we call it the discontinuation, but it is effectively a kind of withdrawal syndrome. I think it depends on a number of things. I mean, obviously the shorter fluoxetine doesn't have that problem because it's a very long-acting medication, but all of the others are relatively short-acting and you can get a discontinuation. It depends on a few things. Number one, how long they've been on it for and how quickly they come off it. And also individual variation. So I've had some patients who don't get any discontinuation and others who get a horrible discontinuation. And I think it's partly just their own sensitivity to medications. It might be a metabolism effect. Venlafaxine does this as well, I should add.
Some people have an awful time getting off venlafaxine.
They do, I agree. But I don't think it's a reason not to put somebody on it. You know, I think you do have to warn them and say, look, if you are on this and you're getting better, then when you do come off it, for God's sake, don't stop it suddenly. You know, come back to me, come back to your GP and we'll talk about coming off it. It's not the end of the world. I mean, you know, we'll come off it gradually. Unless there's a medical kind of crisis here that we need to stop it quickly, you know, we don't stop it quickly. We'll do it gradually and that's okay. So just warn them in advance. Don't tell them that they're going to be hooked on it, but that it's an important process for you to come off it gradually and generally they're okay with it. So I think information is critical and telling the patient what to expect. So that's what I would generally recommend. In terms of other side effects, I mean, sexual side effects I think are important. I always tell patients up front. Some patients will get it quite significant, mainly ejaculation problems. And for them, some of them it's really important. Others, they don't get it or it doesn't bother them. But they're the main ones because the rest of them generally, they pass with time. Another unusual one is excessive sweating. I've had quite a few patients who report excessive sweating, but things like benztropine can be quite helpful with that. That can settle it down. So if patients come and say, oh, I can't stand this sweating, it really bothers me, try a little bit of benztropine, that might help. With OCD, medications, really SSRIs are the way to go. Don't bother with anything else, you've just got to go SSRIs. And often you need to go much higher doses. So we're talking about 80 of fluoxetine, 300 of fluvoxamine, 200 plus of sertraline. I'll put a lot of people on clomipramine who just haven't responded well to the others, so that's the serotonergic tricyclic. Obviously you need to be mindful of things like risk of overdose, ECG changes, so you need to monitor their ECG. And recently, availability, because clomipramine suddenly became unavailable, on the manufacturers just stopped making it. So I had a whole lot of patients going, Doc, I can't get my clomipramine. It was like, all right. So there was a shortage, and this happens periodically with some of the older drugs, which is really annoying, but I don't know what you can do about it.
You need a government dispensary.
Well, I think that'd be a great idea.
At the moment, it's really hard to get flutoxacillin.
I know. I discovered this when. I know. I mean, when I went on the website to look for clomipramine, there's a whole list of drugs that are not available, and they say, oh, and they're very laissez-faire about this. So they just say, oh, look, mild risk, just switch to another medication, as if it was that easy. Like I got really annoyed by this because I thought, no, these patients are really sick. I can't put them on something else, and you can't just switch somebody from clomipramine 300 to another drug. Like, I just thought I agree with you. I don't know what we can do. Maybe we should talk to the AMA or something needs to happen. Anyway, so sometimes we need to augment with another medication, so risperidone, one of the atypicals with OCD. Often they'll have a comorbid disorder like a tic disorder, another compulsive disorder. And then we're getting to CBT, which we'll talk about a little bit. And the CBT for OCD is quite specific. And I would generally, with OCD, I like to find a psychologist who really knows what they're doing with OCD. There are some psychologists who really have no experience, that just don't know what they're doing. I've got a couple of psychologists. A lot of you might know, a guy, Fernando Gomez, used to work a lot down here at Sutherland. He now works in Cogra, private practice. I refer a lot of my OCD patients to Fernando because he's one of the best for OCD. That's his special area. So, okay, so what about benzos? Okay, so benzos are highly effective at reducing anxiety, no question about it. Okay, but you know, the mechanism of action means that they generally have quite a rapid onset and offset. Okay, so they're different to the SSRIs. The SSRIs take weeks to work. Okay, you can't give somebody an SSRI and say, okay, your anxiety is going to go away in an hour. It doesn't work that way. With benzos, they do. But if you're using them occasionally, or PRN, which a lot of patients do, so you're saving it for times when the actual or anticipated anxiety is at its peak, its highest, it can remain quite a potent pharmacological agent. Okay, so it can work, but in light of what we've already talked about tonight, it also prevents the patient from learning to manage their anxiety through other means. Okay, so think about the patient who has social anxiety. Okay, so they go, okay, I'm going to this very highly anxiety-provoking situation, I'm going into a social function, so I'm just going to take a little bit of Valium. I'll just take 2 milligrams of Valium before I go to the party, and I'll feel better. I'm not drinking alcohol, I'm not getting drunk, I'm just taking a little bit of Valium, go to the party, I'll feel better. I don't take it the rest of the week, I just take it when I do that. Okay? You're saying, what's wrong with that? Is there anything wrong with that? What do people think? Is there anything wrong with that? What's wrong with that? Okay, yeah, so you pretty much, that patient, they're reinforcing it. They're at absolute best, they're in a holding pattern. At worst, you're reinforcing their anxiety, because if suddenly you took that Valium away from them, their anxiety would probably be much higher. Oh my God, where's my Valium? Where is it? You know? I've got patients who think they're doing well just because they've got the Valium in the pocket, just in case, you know. I'm not taking it, doc, I've just got it with me. But that's still a safety behaviour, because it's their safety blanket, you know, that's their pharmacological safety blanket, because it's with me, just in case I need to take it, right? So that's if you use it PRN, but if you use it regularly, okay, so now we're no longer using it as a symptom contingent medication. By that I mean, I don't take it just when I feel anxious, I'm taking it regularly. I'm taking it every day. So I'm taking it as a regular medication, just like a regular antidepressant. I'm taking it, you know, 2 milligrams BD or 1 milligram BD or whatever it is that I'm doing, or I'm taking a little bit of Xanax, God forbid, but I'm taking a bit of alprazolam, you know, 0.5 twice a day. And that will suppress anxiety and inhibit learning, yeah, but over time, as we know, the patient then becomes tolerant to the effect. So that 0.5 BD, yeah, it creeps up. So they're going to require higher doses for the same benefit. And they become physiologically and psychologically dependent. So either way, whichever of those strategies you're using, they're not particularly effective, right? So there are pros and cons. The rapid onset, they're well tolerated in the short term. You know, we've talked about the side effects with other medications, and they definitely have side effects. So they are probably better tolerated in some respects, and they can be used PRN as opposed to other medications that aren't really that effective. But the cons we know about, okay? Longer term side effects, they do cause cognitive impairment, they can cause depression, and they prevent exposure and habituation. All right. So what are the rules? I'm not saying don't ever use benzodiazepines, but we need to have some rules. Okay, what are they? And I do prescribe benzodiazepines occasionally. They're a first pass, stopgap strategy. So if we're starting on somebody who's highly anxious on a SSRI, but we know it's going to take a few weeks to work, we might need something in the short term. What are we going to give them? Give them quetiapine? Well, we could. Or give them a low dose of diazepam. Not unreasonable, but you know, lowest dose, lowest potency. So for God's sake, don't give them alprazolam, please. You know, that would not be a good strategy, because it's highly potent. It works quickly, but it wears off, and it's much more likely to cause dependence. So if you give diazepam at a low dose for the shortest time, that's probably a better strategy. Lorazepam maybe as well. It might be slightly less cognitively dulling, but that's quite short acting. Be clear before you prescribe what are you prepared to go up to, and what are you discussing with your patient. Obviously, you need to be mindful. You might need to limit the actual amount of tablets you're giving the patient, and how long you're prepared to prescribe it for. And you need to have a clear plan about what you're doing about the anxiety. It's not just I'm giving you Valium and that's see you later. Okay, what else are we doing? I'm sending you off to a psychologist. We're trying other strategies as well, and the Valium or the benzo will be tapered off very quickly. What if you've already got a patient who's benzodiazepine dependent? Now that's going to happen as well. You'll inherit somebody who comes in and they're already benzodiazepine dependent. I get lots of these patients. Look, the first thing is benzo dependence is not a medical emergency. Benzo withdrawal could be, But if they're simply benzodependent and they've been taking the same amount for a long, long time, you don't need to immediately do something. Go, oh my God, I'm going to have to. And I've seen some very zealous GPs with all the best intentions in the world go, right, that's it, bang, we're bringing you off that right now. I mean, you can stop, pause, think about it, and try and work out a plan. Okay, how old is the patient? Obviously, if you're a much older patient, you're much more at risk of developing problems and complications, particularly if you switch them over or bring them down too quickly. How long have they been using it for? Have they been using it for 30 years? That's a problem, right? It's certainly a problem if you try and bring them off it. What benzo are they taking? Are they taking a shorter or long acting? What's their daily dose? Has that dose been very stable for a long time? Is it escalating? What are their symptoms and signs of dependence and withdrawal? What are their ongoing mental health issues? Are they being properly addressed? And above all, seek advice. If at this point you're just not sure what to do, how to manage it, just either send them to a psychiatrist or maybe an addiction physician to get some assistance. And look, I've learned through this process as well. I've had a number of patients very successfully come off, for example, alprazolam, switch them to Valium over a long period of time, taper them off. Once you get down to the very lowest doses of diazepam, they often struggle, but they do manage to come off. One other patient, a spectacular failure, although she did eventually come good, but only through an admission with John Saunders, the professor of addiction medicine. We agreed that she just had to go on long-term clonazepam. She'd been on Xanax, switched to Valium, did disastrously, was all over the shop. We put her on low-dose clonazepam as a long-term strategy, and she's doing okay. But she was before that really a bit of a mess. So sometimes you win, sometimes you lose with it. But the important thing is, you've got to tailor it to the individual. You can't just have a one-size-fits-all approach with the benzodependence. Yeah. Okay, question?
Can you talk more about clonazepam? It used to be used a lot for restless legs, all these novel agents, and the patients are still on it.
Yeah, look, I mean, clonazepam is very long-acting, as you know. What sort of doses are we talking about? Are you
1.5 to 1, I think.
a total daily dose?
No,
Yeah. Look, I mean, I don't think that's a huge problem if they've been on that for a long time. And depending on the age of the patient, you may not be in a great hurry to get them off that. But depending on what other things they're on and what their overall mental state's like, you may talk about a very cautious reduction. And I'd be doing it, no more than 0.25 over, in one go, see how you go, and maybe several months later think about a further reduction. But I wouldn't be doing it more quickly than that unless you had a reason to, So I think my approach now is to do it really, really slowly, work with your patient, see what they're comfortable with. But there's probably no great reason to believe that they're going to cause long-term harm at really low doses, particularly if they're not escalating the dose. If you're confident they're not escalating the dose, there's probably not any great cause for alarm. If they're not having falls, if they're not other things like that. Yeah. I mean, prevention's better than cure. We don't want people to get on them, but once they're on them, you've really got to weigh up the risks and benefits of getting them off it. Okay, psychological therapy, and I'm just keeping an eye on the time. Okay. Now, we know that the strongest evidence for anxiety disorders is CBT. Okay, that's pretty clear. So what are our cognitive strategies? Challenging negative automatic thinking, the patterns and the typical cognitive distortions that patients with anxiety have. So black and white thinking, it's all or nothing. Catastrophizing, so making a mountain out of a molehill. Jumping to conclusions, mind reading, all of these cognitive distortions that people tend to have that result in the anxious, the avoidance and the anxiety to a certain stimulus. Behavioural strategies, I think behavioural strategies are really the key. The cognitive strategies are fine, but particularly when you're dealing with a behaviour such as avoidance, you need to have behavioural strategies. So graded exposure, and in vivo is real world. Okay, and I want you to keep that in mind when we're talking about PTSD, which is a little bit different. So remember, in anxiety disorders, the feared stimulus is something that doesn't need to be feared. It's something that is inappropriately feared. So the fear is way in excess or completely inappropriate, something that is not something that we need to fear. And we contrast that with PTSD, okay? So for example, and I'll show you a graded hierarchy in a moment. I've got a slide. the idea is if you've got a fear of, a simple phobia, you've got a fear of snakes, a fear of spiders, a fear of heights, you do a ladder of a hierarchy of fears. You start at the bottom rung is the thing that would be least anxiety provoking in relation to that. So if we're talking about spiders, it might be thinking about a spider. Then it might be seeing a picture in a book of a spider. Then it might be seeing a spider in a cage. Then it might be, okay, we get the spider out of the cage and we put it on that chair over there. Then it might be we bring the spider a bit closer to you. Then we might be putting the spider on your, on your hand. All these sort of things. Like we gradually build up the exposure. But we don't move through the hierarchy until you have habituated. And again, I'll show you a slide on how that works. All right. So these are all. This is in vivo. This is real world. This isn't just pretend stuff. This is actually exposing you. If you've got social anxiety, we need to put you in that situation. So a good psychologist will actually do this stuff real world. They might actually take the patient out of the consulting room and do some stuff. Group work will often do this, do it in a whole group. They might take the group of patients to somewhere where they're quite anxious about going. So they're teaching the patient, and systematic desensitization is about teaching the patient relaxation strategies and calming strategies so that when they're feeling anxious, they can do something at the time, in real time, to reduce and lower their level of anxiety. So some breathing strategies, some slow breathing strategies to help them to calm down and reduce their anxiety to a level that they can manage. Okay, so this slide here just shows you about arousal and performance. Okay, Yerkes-Dodson, you might bring it back to medical school and remember this particular curve, and it's a very useful curve because I actually had a patient with ADHD that I was showing this slide to because it actually works for ADHD as well. And just out of interest, if you've got ADHD, your curve is shifted way to the right. Okay, so you're bored at levels where most people are performing optimally. Okay, you need to be highly aroused if you've got ADHD to perform at a level where somebody with an anxiety disorder they're frozen with catatonia at that level because they're just so terrified. But the person with ADHD, the thrill seeker, they're in their optimal performance zone. Now, this guy that I had with ADHD, he was following the Sydney to Hobart in a rubber dinghy, and he was in 13 metre swell. He was loving it. He thought this is great. All right. Now, most of us would probably be terrified. Somebody with panic disorder, they're gone at that stage. They're absolutely gone. They probably couldn't even get off the side of the jetty to some of us might be able to be in a large boat in a calm water. So that just gives you an idea of performance and arousal, But what we're trying to do with anxiety is bring somebody's level of arousal down so that people can function in this zone, okay? So they can be in that optimal arousal performance zone. So this is an example of a hierarchy, a graded hierarchy, and this is the spider example I was just telling you about, okay? So the fear rating, it's 100 out of 100 is the greatest fear. 10 out of 100 would be the lowest. So for this patient, they rated thinking about a spider, it's about 10. Looking at a photo, looking at a real spider in a closed box, holding the box, letting it crawl on your desk, letting it crawl in your shoe, finally getting up to crawling on your bare arm, okay? That's the 100 out of 100. Maybe some of you in the room have a fear of spiders, I don't know. It's not an uncommon fear, as you can imagine.
Surely that you don't need to attain that for success, though. I mean, surely if they could regularly get to sort of the 80.
Well, a pure CBT therapist would say no. In order to completely eradicate your fear, we go on the whole hog here. But this flooding, graded exposure, just to give you the difference, graded exposure is starting from 10 and working our way very gradually down the list. Flooding is throwing you straight into 100, right? So some people would advocate flooding, like let's just cut the crap, let's just go straight to 100. And that can work, right? Because it's just getting you there, it's just getting you straight there. But I wouldn't advocate that approach. I don't know that that's humane, right? It's like throw the child in the deep end of the swimming pool and he'll be okay. He'll learn to swim, as opposed to just dipping your toe in the shallow end and then gradually, but he might drown. Well, maybe not. Now this slide, I think this is a really important slide, okay? So anxiety and time. Now what happens if at the beginning, at the first point, we've got exposure to a stimulus. Now what happens immediately is the anxiety levels go up quite rapidly, and it motivates the urge to escape. Now if that person escapes at that point, what do you think happens to their anxiety? It drops very, very quickly. But they learn nothing. Patient learns nothing, and they get sensitized to, and in fact the next time it'll go up higher. So that curve goes up. Now the common mistake is that if they stay in the situation and they don't escape, I say to patients, what do you think? I don't draw the whole curve, I just draw the first bit. I say, now, you stayed there, you haven't left, what's going to happen to your anxiety? And they go, oh, it's just going to keep going up. And they point to the roof, it's just going to keep going up. I said, no, it won't. It can't. I said, what's driving your anxiety? You know, adrenaline. How much adrenaline have you got in your body, right? It can't continue to pump out adrenaline indefinitely. There's only a certain amount. Your anxiety will gradually subside. It has to. It physiologically cannot continue to go up. You just can't do that. So you stay in the situation, it will come down. Now, if you do that, and then the next day you get exposed to exactly the same situation, what do you think is going to happen? The next line, the lower line. And if you do the next one, each day that line, that curve becomes a little bit less, right? So that's the whole point of graded exposure, and we call that habituation. So habituation is where your anxiety gradually diminishes because you've been exposed to the same thing over and over again, and you've learnt that your anxiety will, over time, reduce. So it's the opposite to sensitization. Sensitization is your anxiety heightens, it gets greater. Habituation is it goes down, less and less. Does that make sense? That's what we're trying to teach patients. So it's a gradual reduction in the physiological arousal symptoms with repeated exposure to the same feared stimulus. And extinction is a similar concept, and it's where you get an eventual cessation of a learnt behaviour, like a safety behaviour, when it's no longer reinforced. So we're trying to extinguish safety behaviours and habituate to the feared stimulus. That's really the goal of cognitive behaviour therapy in anxiety. Okay? All right, let's move on to PTSD. I've already told you it's placed in a separate category, so it's in the trauma and stressor-related disorders. The main differential in adults is acute stress disorder and adjustment disorder, or adjustment reaction if you prefer, I don't mind, with anxiety or mixed anxiety and depression. So PTSD has to have gone on for greater than 1 month, and acute stress disorder is less than 1 month. So that's effectively a time course differential. So I don't particularly like these classifications, you know, like, okay, when did this happen? Was it 30 days ago? Okay, like, it's a bit contrived, isn't it? It's a bit artificial. It's really the same disorder, it's just a matter of days. It used to be like the old schizophreniform versus schizophrenia, 6 months, more than 6 months. It's the same condition, effectively. PTSD will often have a delayed expression though. So in other words, often the patient will have the trauma, but they won't have the symptoms for quite a while afterwards. So they'll have a delayed reaction. So initially they'll be quite numb, in shock, but then they'll develop a lot of the other symptoms, and I'll show you what those symptoms are more than 6 months later. So they won't necessarily have that acute stress reaction, they might have something quite different. Now adjustment disorders or adjustment reactions, they're really characterised by a marked distress that is out of proportion to the severity of intensity of the stressor. And it's got to take into account the external context and other cultural factors, okay? So adjustment disorders are really quite common. We see them all the time with people who've had relationship breakups, problems at work, other crises in their life. And it's reasonable to call these adjustment disorders. So this is the definition of the stressor. Okay, so when people think, well, does my patient have PTSD? Well, have they been exposed to this? Actual or threatened death? Well, obviously the actual death isn't their own, clearly. Someone else's actual death. Have they been exposed to that? Serious injury or sexual violence? So that's the stressor has to be one of those categories. Did people realise that? Yeah? So direct experience. So they have to have have it happen to them physically. They've had to witness it, so they might have witnessed an actual death.
So is child sexual abuse in terms of child sexual abuse in that category?
It would be, because that would be sexual violence. Sexual abuse would certainly be sexual violence. Yeah.
You often end up with the borderline personality.
They do. That's a separate diagnosis.
I know.
Yeah. And I'll talk a little bit about that in a minute. The difference between a single trauma and cumulative trauma. Okay, so I think, and this is one of the complexities of this area. So it could happen directly to them. They could witness it. So, for example, if you witness somebody dying in front of you, it could be dying in a car accident. It could be you could witness a shooting, for example. That would certainly be exposure to actual death, or even threatened death. You could be in I've had patients who've been part of a hold-up, a robbery. Somebody comes into a bank or into a shop, pulls out a gun, threatens to shoot people. That's exposure to threatened death. It could be to you, or you could simply be at the back of the shop and you could see people being threatened by a gun. That would be certainly part of that stressor. Learning of it, now this is interesting. So you learn of it occurring to close family or friend. Okay, so you weren't even there, but somebody close to you told you that it happened to them. That could be sufficient to be a stressor. So this is a new part of the classification that this has been put in. So just learning about it. And the last one I think is really important. It's about first responders, ambulance, police, emergency workers. Repeated or extreme exposure to aversive details of traumatic events. Okay, so people collecting human remains. Or police, and I had a police officer, I've got still treating him, involved in child abuse investigations. So didn't directly have any interaction with a lot of stuff, but as part of the investigation process was dealing with this all the time. So what are the core symptom clusters?
So what was he exposed to? Photographs or
Well, stories, statements.
traumatised people?
Yeah. And witness statements and other, just the whole process of, and having to maybe go to court, hear about, perpetrators, victims, the whole thing. Just immersed in the whole thing, really, yeah. Yeah.
These are all very individual, but collectively victims of war, entire societies collectively may have PTSD and I think do better than individuals.
Yeah, that's a really interesting point you make. And of course, the classification system can't hope to capture a society. This is very much an individual classification system. If a country has been at war, then you could argue that that entire country has been afflicted by trauma. And I think it's the cohesion of communities, whether it be a village, a city, a town, a country, the cohesion or lack thereof is going to be absolutely critical in terms of how people recover. So I think there's lots of problems with the diagnosis of PTSD in that context. It can't possibly capture all these sorts of things. But just going through these are the core symptom groups. So there's 4 groups. There's intrusive symptoms. So this is the bit where things are, if you think about back to OCD with recurrent intrusive thoughts which are ego dystonic. These are intrusive memories which are basically reminders of the trauma. So they can be dreams, flashbacks, physiological reactions when you're exposed to things which remind you or symbolise or resemble the trauma. Okay, so that's pretty straightforward in terms of understanding. Then the avoidance, again, similar to anxiety disorder, your efforts to avoid any of those memories and feelings and external reminders, and also the numbing, psychological numbing. Negative alterations in cognition and mood, so dissociative amnesia, so complete forgetting the trauma and not being able to remember it. Then this persistent negative belief about self, others and the world, so having this very strong core beliefs that have been changed. Negative emotions, anger, fear, shame, feeling detached, and this inability to experience any positive emotion. So this is really very, very strong. And then marked alterations in arousal, so being highly hypervigilant, startle response, irritable, not sleeping, and then the whole gamut of self-destructive behaviours, addictive behaviours. Yep.
Of course, people in those situations,
Yep.
there's a certain, only a small percentage of them
Yep.
would end up with PTSD, wouldn't it? It's a small percentage. And
Well, it depends on...
interacting with that situation.
Yeah, look...
Lots of these people, like the first responders,
yeah.
and including doctors and nurses,
Yes.
are able to cope with this.
Yeah, so look...
Obviously, without developing PTSD. And
Yeah.
the second question was,
Yes.
in these situations where you have big traumatic events,
Yes.
people involved, they always say, oh, the psychologist, bring the psychologist in, give them all counselling.
Mm.
Is that a good idea or a bad idea?
Okay.
Does it reinforce the situation?
Sure. Okay, I'll answer those two questions. They're two very good questions. So the first one is the trauma itself sufficient or specific for developing PTSD? Certainly you need the trauma, but factors in the individual are critical. So some people will already have psychological vulnerability to developing something like PTSD. They may already have a mental disorder. They may have anxiety and depression prior to being exposed to the trauma. They're much more likely to develop PTSD because of pre-existing vulnerability. They may have a personality disorder. Other people will be more resilient psychologically, and therefore if you put person A and B in exactly the same scenario, person A may be much more likely to develop PTSD than person B. And those things make sense, right? We understand that. But also, it's not just what happened at the time of the trauma, it's what happens after the trauma as well. Some people are going to have better social support systems. They might be in close confiding relationships. They might have strong networks in their workplace. They might have a whole lot of other things that protect them, not just at the time, but after the trauma. And then that brings in the issue of what do you do at the time. This whole thing about debriefing, critical incident debriefing. When I was going through psych training, this was a big thing. I remember being on duty at Sutherland Hospital when we had the waterfall train disaster. People would remember that, right? And we were on standby at Sutherland, but I remember there were teams of psychologists that went racing down there and doing all this debriefing at the time. We don't do that anymore. It's been debunked. It's not proven to help. In fact, it makes things worse. You do not automatically, routinely debrief every individual who's been exposed to a trauma. That is not helpful. What you do is you provide psychological first aid. You say to people, right, this is terrible. We're here to help you, but you need to let us know how you're feeling. You need to go back to your usual supports, your families, your loved ones. But if you're having symptoms, this is what you need to do. Come and talk to us. But you don't get everyone in a room and go, right, let's talk about it. Let's go through this. You don't do that because in fact that makes things worse for some individuals. For others it does nothing, it doesn't help. But for some people it makes it worse. So you absolutely don't do routine group psychological debriefing. You provide easy access to support for people who need it. And for a lot of other people, they just get on with things and they don't need that. Yep, and I might just see if anyone else has got a question because you've asked quite a few. Yep, Phil? Yeah.
Is it age-related, like some of the old diggers and that? They went along quite well, and then all of a sudden in their 50s and 60s, they all of a sudden start getting their flashbacks and all of that. Is that unusual, or is that more common?
Look, I can't say specifically, but I would say the cycle of PTSD is very much a developmental cycle, and there'll be things throughout a person's life that will trigger, and it could be, for example, having children grow up, retiring, having loss of meaning in other areas of your life. So, you might come back from the war, be okay, but then developing some other health problem or loss of meaning because your mates have died or you've left work, and then it suddenly stirs up something else, So the problem is that, once you've been exposed to the trauma, you can't be unexposed. So that's part of your life story now, and you carry that with you. And then when other things happen in your life, it might be the straw that broke the camel's back. So you've been stoically carrying this on, and then suddenly something quite trivial can then just be the thing that breaks you, and then all that other stuff comes up. So that might be an explanation. I think there's a whole lot of things, but we need to understand things as being cumulative, and that's the best way I can explain it, I think. Yeah. Look, I just want to touch on this idea of PTSD as being an evolving idea. I mean, initially it was described by military psychiatrists, you know, so post-World War I, you know, this idea of shell shock, combat neurosis. I mean, World War I was the big, you know, the Great War. It was where we first really understood that people coming back and surviving such a war developed major psychological issues. And it was, you know, when psychiatry was sort of going through a real growth phase anyway. And of course, you know, World War II, we saw more of it. But, you know, in the last few decades, it's really moved into the civilian domain. And of course, you know, understandably, the role of litigation and compensation, as insidious and pernicious as that might be, has been inextricably linked with PTSD. And some of those changes to the definition of PTSD, and this is an American classification, remember, I think are linked to the whole compensation process. So you can use that definition in a court of law to qualify for the diagnosis. And once you qualify for the diagnosis, you may be eligible for compensation. So I think the two cannot be pulled apart very easily. So, you know, I see a lot of patients, as I'm sure you do, people on work cover who've had workplace injuries, maybe had motor vehicle accidents, and this whole spectre of, is it PTSD? Are they eligible for some compensation? Comes up. Complex PTSD. This is where persons had developmental trauma, and it's not just a one-off, but it's happened, you know, repeatedly, cumulatively, often with a lack of support. I mean, we all know about the horrors, the atrocities that have occurred within our institutions. There have been royal commissions, and people who have only come forward 30, 40 years later, having hidden what happened to them or not been believed. Well, they've been re-traumatised, I think, by having to tell their stories, but also by not being believed is a trauma in itself or is a betrayal. So you can see that this is very different to somebody being in a car accident. I mean, how can you compare those kinds of traumas? They're completely different, and which is also different from somebody who's been in a war or lived in a war-torn country. I mean, we're calling it all under PTSD, but these are entirely different processes. I struggle to see them all as the one disorder, but we unfortunately don't have a better way to categorise it. So the age of onset and the disruption of attachment relationships, I think, is the critical issue here. You know, how old were you when all this happened? And how did it impact on your attachment relationships? You know, if you weren't believed by your parents that you were being abused, what impact does that have on your attachment to your key attachment figures and your trust in them, as well as your trust in adults generally? And of course that doesn't just give you PTSD, it almost certainly is going to lead to personality problems. So in primary care, where do you see it? Well, I think motor vehicle accidents are going to be very common, and they would certainly qualify for a stressor, and I'm sure you would see this all the time. Sexual assault in its many forms is going to be, I think, a critical area for you, and domestic violence, I would suggest, would also be a big area for you. I see lots of first responders. I've got lots of police officers. I'm sure you do as well. Many of them, unfortunately, who've had to leave the force, have been medically retired. Some AMBOs as well. Often it's a cumulative trauma, and it's the last one that just tips them over. You know, the last one that's it, can't do it anymore. The interesting one is the last one here, bullying and harassment. Does this qualify? Do you think that qualifies? You've been bullied and harassed in the workplace? Is it serious injury?
Yes, it makes your place of being unsafe for you. If you can't go to school and be safe, then that's hugely significant.
But does it qualify? Exposure to actual or threatened death, serious injury or sexual violence? What do you think? What do people think? Serious psychological injury? It's the only way you could get it. I mean, it's certainly none of the others, is it? I mean, sexual harassment, sexual violence, that's a very long bow. You could really only say it was serious psychological injury, but there's nothing there that says injury has to be physical. You know, I would argue that a lot of my patients have been very psychologically injured by persistent bullying. It's often vertical bullying from senior managers, low-paid workers, administrative staff.
Facebook.
Well, it's on social media as well, you're right. So could that be PTSD? I mean, I think we're taking it in a new area, but I think PTSD is going in that direction. If you look at the core symptoms, they're getting nightmares, flashbacks, avoidance, detachment. I mean, they're getting all those things. So why wouldn't it be PTSD? I mean, it doesn't really fit into anything else. Maybe it's more than an adjustment disorder, in my view. It's going on for longer than that. It is complicated, unfortunately. I don't know if I've got a slide, but I've got a few patients who are on work cover, income protection, and it is complicated by the legal system. You know, I've got a couple of patients where they've been told explicitly by their lawyers, look, you know, you don't want to go back to work, you don't want to do volunteer work because it's going to harm your case. You're not going to get a good payout. Have you had patients like this? I mean, to me, that's the anathema of recovery. You know, as a clinician, I'm saying, look, okay, I'm not your lawyer, I can't give you legal advice, but you're not going to recover. When is this going to court? They told you 6 months ago, they told you 12 months ago it was going in 3 months. It's dragging out. Sure, I can keep medicating you, but if you don't actually want to participate in your recovery, if you're hanging on for something that isn't going to happen, you're not going to get better. And I think this hanging on for the compensation that may or may not ever occur, I think is a real barrier to recovery, and I think it's one of the real problems in our system. It's a real problem in our system, unfortunately. So just quickly then, the CBT and PTSD, it's not in vivo exposure generally, it's imaginal exposure. And this is really important, and it's important when you are referring to a psychologist that they actually know what, I would hope that they know what they're doing. But in anxiety disorders, the fear is excessive or unrealistic. In PTSD, the feared stimulus, it happened. It actually happened, right? So it may not be realistic that it's going to happen again, but you don't want to necessarily do an in vivo exposure to more violence, right? I mean, why would you want to do that? But you need to, what you want to do is give them imaginal exposure to the memory, because the memory is not something that can hurt them. The memory is something that distresses them, but the memory cannot hurt them. The memory can merely be distressing. So what you want to do is make that memory less distressing so they don't avoid the memory and avoid reminders. You want them to be able to see that and go, okay, I don't like it, it's unpleasant, but I can deal with it. So that if a reminder comes into the mind, they go, oh, they don't do this, they go, okay, all right, yep. And that's imaginal exposure, okay? It's hard work, it's difficult, but you know, through cognitive reprocessing, it can work, okay? Some people use EMDR. There's a number of ways you can do it. A psychologist who does this kind of work should be doing it. I don't do it myself. It's not a therapy I do in my rooms because it's, you know, you really require a practice that's doing this kind of thing, okay? But that's what a psychologist working with PTSD should be doing. Looking at the trauma, processing it with the patient in that way, okay? The pharmacotherapy, it's going to be similar to other disorders. Prazosin, an old drug, alpha antagonist, can be useful in managing hyperarousal and nightmares. I've used it with a few patients getting nightmares, quite effective. Keep it in mind. Other than that, you know, the whole gamut, SSRIs, SNRIs, benzos where indicated for short term can be helpful. Comorbidity will be the rule. Most patients will have depression, GAD, and substance abuse, as we know, extremely common. So treat all comorbid issues, including substance abuse. You need to get on top of that. So when do you refer to a psychologist? This is broadly, not just with PTSD. So if you've got a clinically significant anxiety disorder, nearly everyone is going to benefit from seeing a skilled, experienced psychologist. So do not hesitate to refer. I would recommend thinking about a psychologist. I would hope that most of you would have a small group of psychologists that you feel confident in and trust and refer to. Do most of you have a small group of psychologists you can refer to? Yeah? That's good, because I think, you know, you don't want to be a scattergun approach. You don't want to be just, you know, sending them off left, right and centre. I think if you can find a group of psychologists that you use regularly, that you trust, that's what you need. You know, maybe preferably with an adolescent one thrown in, you know, just so you know, send somewhere to send the kids and the young people to. But generally, a mix of male and female, and a small group, half a dozen, and that's good, because psychologists are extremely useful and you need them. Generally, I find clinical psychologists are going to be more experienced and skilled, but I know that There are a lot of registered psychologists out there, but definitely you need to have a few clinical psychologists in your referral list, okay, because they will have more skills and they definitely have more experience and more training. You need to find someone who tailors to the CBT to the disorder. So again, somebody who's experienced in OCD, somebody who's experienced in PTSD, that's always helpful. This idea of non-specific supportive counselling, it just doesn't work, okay? The patient might feel better for 2 or 3 sessions, but after that, they'll come back and say, look, I'm not getting anywhere. I just don't feel like I'm making any progress. You know, nice person, you know, we have a nice chat, but I'm not getting anywhere. So the patient will usually tell you, but also the letters that the psychologist is sending or isn't sending you will give you some idea as to what's going on. And then combining treatment, you know, don't hesitate to use medication. Most psychologists are pretty open to it. Some of them will even recommend it. I'm not real big fan of psychologists telling me what medication to prescribe, but you know, as long as they don't go too hard on it, you know, most of them are pretty open to co-management. So when do you refer to somebody like me? So if they haven't responded, obviously, you know, so you've gone through the usual path, you've given them an SSRI, you're seeing a psychologist, they're not getting better. Or they're not tolerating medication, they're getting side effects, they're not able to maintain a therapeutic dose for whatever reason. If they've got comorbid diagnoses, or the diagnosis just isn't clear, just not quite sure what's going on, could they have something else going on? Could this be a psychosis that you just haven't picked up? If the functioning is just persistently impaired and they're just not getting better and it's impacting on their relationship, impacting on their work, you're really worried about them. Obviously the benzo issue we've discussed. And look, I find that, you know, I work together with psychologists a lot. I'd say at least 50% of my patients also see a psychologist, particularly in the complex and severe cases of anxiety. And I've got a number of psychologists I work with at Wesley, plus Fernando, who works in a different practice. I mean, they're probably the people I use most regularly, but I'm very happy to work with all of the psychologists in the St George and Sutherland area. You know, so no dramas with that. And it works well generally, you know, no problem with communication. So, summary. Okay, just to give us an overview, anxiety, common across the lifespan. We know that. All ages, both genders, maybe females a bit more commonly. And you will be the first point of contact. That's logical, and also because physical symptoms are a very common first symptom. Patients will often think they've got something wrong with them physically. They won't necessarily believe that it's an anxiety disorder. Treatment often requires a multimodal approach, medication, CBT. We talked about benzodiazepines used with caution, PTSD being increasingly identified, and particularly in a whole range of areas in civilian life. And working with psychologists and psychiatrists will help you in primary care in managing anxiety disorders. Happy to take any questions before we finish, if there's anything else that people wanted to ask. Yes?
I'm sorry if I missed it, but the specific psychotherapy for OCD?
Graded exposure and response prevention. So if you've got a ritual like washing your hands because you've got a germ, you believe that you've been contaminated with germs. So the exposure would be to the thing that you fear, the obsessional belief about germs. So again, graded exposure. You wouldn't come in and throw dirt all over the patient initially, but you might start with the idea about talking about germs but eventually, you know, getting to the point and trying to prevent the response. So response prevention is, okay, what would the patient normally do? They'd go and wash their hands multiple times. So you're trying to get them to not respond in that way. For the mental rituals like praying and counting, that's a harder one because you can't physically see what they're doing, but you're trying to get the patient to stop doing what they're doing mentally in response to whatever they're fearing. And initially it might simply be delaying their response. So they might, if they were going to do it instantly, you might say, well, they can put it off for 30 seconds or a minute and then they do it. And eventually they can get better and better at delaying the response and then preventing it altogether. So it's just a way of, okay, we start off with, you know, the bottom of the ladder. Okay, we're good at that. We move up the ladder and so forth. And there's a whole lot of things we do. I mean, for example, I've got a patient at the moment who has this obsessive thought about suicide. He doesn't want to suicide, he's got no interest in killing himself, but this idea of suicide pops in his head all the time. And it's very distressing to him. So one thing we've got him to do is just say the word out loud, suicide. Not well out loud or in his head or when he's having a shower, because he's a bit embarrassed about it. So he's just suicide, suicide, suicide. So just to hear the word over and over again so that it almost becomes numbingly boring, or writing it down. So rather than avoiding it or making it as something to be feared, it's just another word. Like I said, well, suicide, what is it? It's just a word. You're not interested in harming yourself. It's not like it has any power other than just the word. Okay, so you're just trying to get the patient to see that these intrusive thoughts are just that. It's just a thought. And if your thought was about knives and about killing and stabbing someone, if you had no interest in doing that, then eventually you would be able to pick up the knife and hold it and go, okay, it's a knife. You might even be able to do it in the vicinity of the person that you thought you were going to stab. And be confident that you weren't going to do it, you know? But that's probably a long way down the track. But that's the ultimate goal, you know, to be that much in control that you are not going to act on the impulse, you know. People often get freaked out with that one, you know, mothers, you know, who've got newborn babies and they want to kill their baby. Now, obviously that one you've got to make sure they're not psychotic, but most of them aren't. They're just very, very obsessional. They're actually at the lowest risk of harming their babies. They're so terrified they're going to do it. They're not going to do it, but they just feel awful about it. And then
you mentioned online programs, anxiety. Do you have any particular favourites? And what about for people with, say, OCD? Are there any specific ones for them?
Yeah, look, very good question. I don't actually have anything to give you tonight. Maybe that's some homework I need to do. Look, the psychologists use this all the time. I don't. I suspect that you know, if you looked up, you know, Beyond Blue, St Vincent's Hospital, CRUFAD would probably be a good website to look at, because I mean they're a very well recognised anxiety disorders treatment centre. Black Dog maybe. I mean, Black Dog's more depression, but they probably have some resources. I don't. No, I don't. I'm not. Probably because I'm not doing a lot of the CBT myself. But yeah, yeah.
With respect to the knives, what is your dotted line in the sand for mandatory reporting?
What, I missed the first part of the question.
With respect to the knives.
The knives, yeah.
What is your dotted line in the sand for mandatory reporting?
Certainly not OCD. If they've only got OCD, I can't think of anyone I've ever reported. I would have to think that the person was psychotic, in which case I probably wouldn't be reporting them. I'd be admitting them to hospital, you know, because if you've got a woman who's got a postpartum psychosis, that's a medical emergency, a psychiatric emergency. So mandatory report's kind of pointless. I mean, you ring fax, you know, 3 weeks later, oh, hello, did you send us a form? Like, forget about it. The baby's dead, so, you know, like mother's in hospital. I can't think of a situation. But obsessional thinking about harming a child, it's about reassuring, no, it's not going to happen, but I can see you're distressed, you need treatment, let's get you on some treatment. You need medication, are you breastfeeding? Okay, let's work through that. But yeah, it's not a mandatory report. No. All right, I know we've gone pretty late, but thank you for your attention. Okay.